Yeah, it looks like it's calmed down. Okay, so I'm going to go ahead and introduce our first participant today. Julie Sonier is going to join us from Mathematica, and she's going to she's going to introduce herself and then do her presentation. And then we'll go to that point and we'll introduce our next presenters after that.
Great, thank you so much, Norm. And just while I'm getting ready to share my screen, if you could confirm when you can see the slides or that you can see them.
I can see them. Yep.
Excellent. Hi, everyone. My name is Julie Sonier, and I am a senior fellow at Mathematica in the state and local division, and happy to be here with you today. And like to thank Norm and Charles for the invitation to be part of this event. Just wanted to give like a real high overview of our topic for today. Most of you, I'm assuming, are familiar with the Rural Health Transformation Program. It is a $50 billion 5-year initiative that was included in HR 1, which is the big budget and tax bill that was enacted in July of 2025. The purpose of the RHTP specifically is to support states to overhaul and strengthen rural health care. Many of you are also aware that the implementation of this program has been on a very rapid timeline. So the Notice of Funding Opportunity for states was issued on September 15th. States had a little bit over 7 weeks to prepare their applications, which were due on November 5th. And CMS announced the funding awards on December 29th. So a very, very rapid time frame. What I want to talk with you today about is the role and value specifically of all-payer claims databases and hospital discharge databases in state rural health transformation program activities. This is actually a little bit of a follow-up to a conversation that we started at NAHDO's annual conference in November, where we had a panel discussion about the value of data in RHTP, but it was just at about exactly the same time as states were submitting their applications. So we didn't know specifically anything at that time about what states had proposed. So today we do have that information, or at least some of it. And so we'll provide some information and perspective on what states are doing in their RHTP initiatives. But specifically, I want to spend most of my time talking about how state APCD and discharge data can be useful to support program operations and implementation, and also monitoring and evaluation. So just a real quick reminder first about the application process itself. So states were required to include information as background about rural demographics, health outcomes, healthcare access, rural facility financial health. And there are specific examples of those things. I think the second and third categories here are places where states that have APCDs and discharge databases would find them particularly useful to for example, come up with rates of chronic conditions, child and maternal health outcomes, things like distances that people travel to get care. But as I mentioned, I want to spend most of my time talking about the future, which is data, how these types of data can be useful to support operations and implementation. Recognizing too that states only had such a compressed time frame to put together these applications. So one of the things that I have been really interested in is the extent to which these databases are already reflected in what states planned to do. But I think that there are still opportunities to kind of build those relationships within states to make sure that policymakers are aware of this incredible resource that is already available to them and that can be useful to run these programs. So I think there are two potential big opportunities as far as using this data to support operations and implementation of programs. So the first one is to think about using it as a tool to help allocate funding within the state. So for example, identifying rural communities with the highest rates of chronic conditions that the state might be targeting in its program, high rates of avoidable hospitalizations, places where people are traveling, especially long distances, or there are other types of barriers to care like that. The second opportunity is to use this data and information to support the development of payment reform models, which is something that a number of states have included in their applications. So that might include things like using that data to select targets for quality and cost, or using the data actually in an implementation way to actually calculate and monitor quality and cost, and potentially to support the calculation of reconciliation payments to providers as well. Along with those opportunities to support operations and implementation, there are also some complicating factors, and none of this is new news to people who spend most of their days working with these databases, but timeliness of data is always a potential barrier if there are long lags associated, between the time that services are provided and the time that we can really use the data to provide a good analytic picture of what's happening in the state. Another thing to consider is that some of the interventions that states are going to be putting in place might take a long time to show effects. So a really good example here is chronic disease prevention. And then finally, we always have to consider gaps in the data and the limitations that those introduce. So especially the gaps, for example, in the covered lives in all payer claims databases. And the strategies to address those gaps, I think, are going to depend on the specific question that's being answered. I want to move on and actually give you a few observations from my own review of state applications about some of the very common themes across states around what states are planning to do with the funding from RHTP. So kind of like all across the board, saw initiatives related to telehealth and remote patient monitoring, chronic disease management, wellness and prevention, maternal and child health, value-based payment, and a couple of different kinds of value-based payment initiatives. So there is a very large base of activities that states are planning to do to support providers in being ready to move towards value-based payment. And then some states are actually planning to implement new or expanded value-based payment models. I saw a lot about regionalization of services and or kind of data to support regionalization. Workforce initiatives, obviously a really big one, and then technology. So either advanced analytics or data infrastructure. So those are just some of my observations from the applications that I have had a chance to look at about very common things that states are planning to use this funding for. Moving on to metrics and evaluation. So state applications were required to include at least 4 outcomes for each initiative that they were proposing. And at least one of those outcomes has to be measured at a county or community level. The other thing that states needed to include in their applications was baseline data and targets for each outcome, so where that's possible. And it is not always possible if it's, for example, implementing a brand new program that doesn't exist today. A little bit of a kind of a by the numbers from my review of state applications. So Mathematica has copies of the full applications from 40 states. From that, I noticed at least 5 states are using at least one discharge database metric in their metrics and evaluation. At least 17 states are using at least one APCD metric. And then really interesting to me is that all of the states that are using a discharge database metric are also using an APCD metric. And this was a little bit surprising to me because I had kind of expected that the discharge databases might serve as a substitute for APCDs in states that don't have APCDs. But that is not something that I noticed in my review of the data. What I will note is that I've not read all these applications word for word. This is really based on keyword searches of terms that are related to discharge data and APCDs. But if you haven't had a chance to review the metrics and evaluation section of your state's application, that might be a good place to start. So also wanted to share some of the most common topics for metrics that states are planning to use from APCDs and discharge databases. So very high up on the list are lots of states are planning to look at preventable hospitalizations and ED visits, specifically whether their initiatives result in reductions in those metrics. Hospital readmissions is another big one. I saw a lot of states that are planning to use metrics related to telehealth. So they want to increase utilization rates of those services and plan to monitor that using claims data. Both virtual visits and remote patient monitoring. A lot of metrics around maternity care, specifically prenatal and postpartum care. Using metrics are related to preventive care, so well visits, cancer screenings, those types of things. And also I saw lots of states that are planning to use either behavioral health or dental metrics as well. A little bit less common, but it is there in the applications, is the use of APCDs to do things like measure reduced travel time and distance to services, measure the ratio of providers to population, so workforce related type metrics, and then nutrition and lifestyle counseling or other wellness programs as well. There are also some challenges related to the metrics and evaluation. So similar to the operations and implementation, the timeliness of data is an issue that's always important with these databases. So data lags, particularly frequency of measurement. So, if it's possible to measure these things more than annually, that might provide a lot of value to state policymakers who would like to use this data to know whether their programs are having impact. Data gaps. So, I already mentioned with the all-payer claims databases, there's that usually a very large gap in the self-insured commercial populations. Also, the uninsured is another big one to think about, and people covered by federal programs like the VA typically are not in these databases. Discharge databases have their own challenges in terms of data gaps, and that has to do with the scope of services. So usually we only have services that are provided inpatient, outpatient hospital services, and can't really use it to tell anything about what happened upstream of those services, or other like prevention and wellness types of services. Geography is another limitation there, where unless you have the ability to share data across states, which I know some states do, to be able to see, for example, which people from my state got care in other states, is a limitation to overcome. And then just having information about payments. So typically in a discharge database, we have charges, but not really the ability to tell anything specific about how much was paid for that service. I mentioned earlier that some interventions might take a long time to show impacts, and that's also a challenge for metrics and evaluation. Another one that is also, I think, going to be important has to do with the nature of rural healthcare. So in a lot of cases, we're going to be talking about low volume facilities or low volume services, and that has implications kind of statistically for our ability to detect meaningful improvement over time. Border crossing, I already talked about that a little bit in terms of the geography challenges for discharge databases. And then also, many states are going to want to be able to benchmark themselves to other states or national, and that's typically a limitation of state ABCDs and discharge databases, is that we just don't have that many other sources that we can use to tell, is what's happening in my state the same or different from what is happening in other states. My last slide here has to do with some of the opportunities related to the use of these databases to support RHTP. So I think the biggest opportunity by far is that health data organizations are a trusted source of information. And there are very few other sources of information available to do the kind of analysis related to geographic variation within a state, community level analysis. So I think health data organizations are really well positioned to support the RHTP programs. Another big opportunity, I think, for states is to share information and lessons learned across states. So NAHDO is a great forum for doing that, and perhaps other forums as well. Sharing data and methodology so that we avoid reinventing the wheel. So we're all trying to invent the same thing at the same time. It would be a good idea to share those ideas. And then finally, I would suggest that states think about enhancements to these databases that could further support the state's work under RHTP. So for example, if there's a big payment reform initiative, maybe it's time to start thinking a little bit broader or differently about non-claims payments, or integration of a claims database with clinical or other data sources. So let me stop there and hand it back to Norm.
I always have trouble getting off mute. So thank you, Julie, for your presentation. So now we are going to hear from our friends in the state of Nevada. We're going to talk to us about how they are incorporating health data into their state's RHTP grant program. So,
Norm, Maddie is under the weather today, so it's just going to be me from.
yes.
Oh, actually, we have two additional team members, Alicia Roman and Dylan Mamlov as well, but primarily hearing from me today.
Great. Thank you, Jonathan. And so this is Jonathan Chastain, who's from Nevada, and he's going to introduce himself and his topic, and we're going to find out what great things they're doing.
Yeah, thank you, Norm. Thank you for the invitation. I'm happy to be here and be talking about the program. Just as an introduction, I am a clinical informaticist working with the Nevada Health Authority and Nevada Medicaid through a state university partnership with the University of Nevada, Reno. I have the opportunity to work with the amazing NVHA team on the RHT program. And I'm going to give you today just kind of a brief overview, broad overview of the initiatives that we have and how the data resources that are available to us played into designing those initiatives and the metrics that we're looking at. Consideration of data resources, and I apologize, I don't have any slides prepared for today, more so just a kind of conversational and chatting about the topic, but the consideration of data resources were really highly integrated into metric development for Nevada's initiatives. During the development, we assessed the feasibility with the Office of Analytics, and many metrics were chosen based on alignment with the data resources and capabilities that we have. The main data resources that we are planning on using to support the program are the all-payer claims database, which was previously described for Nevada, which we've just launched, Medicaid-specific claims data, the BRFSS, and Nevada Vital Records. We'll also continue to assess for emerging resources that could be valuable as well. My notes here, the Office of Analytics does continue to be an integral partner in this program as they are building out dashboards and performance evaluation capabilities for the NVHA to monitor the program going forward. So chatting a little bit about the initiatives that we have developed. The first is our Rural Health Outcomes Accelerator program. This will fund evidence-based initiatives aimed at improving rural healthcare for chronic diseases and focuses primarily on behavioral healthcare and primary care. Initiatives can include technology in support of innovative care models and care management services. And it will also fund incentives for participation in value-based payment arrangements through a rural value acceleration network. A portion of the funds awarded through this program will be used to improve health data sharing and interoperability functions. The metrics that we'll be focusing on for this initiative include increased perinatal care utilization, improved care management for mental health and substance use disorders, and mortality outcomes. And the OOA is instrumental in establishing baseline measures, as well as measuring and monitoring those measures of utilization and outcomes going forward. So they'll definitely be using the APCD to do things like modeling HEDIS measures for high priority populations that we'll be able to track. Our second initiative is the Nevada Rural Health System Flex Fund. It establishes a flex fund to modernize and enhance existing facilities and rural healthcare system infrastructure. Also helps expand rural and frontier affiliation networks and shared service models, and funds resources to improve revenue cycle management. So for this, we'll be looking at things like new regional purchasing and sharing agreements, healthcare transportation access, mobile care unit availability, critical access hospital and FQHC sustainability. And the OOA is supporting this evaluation through measurement of service type utilization, changes in resource availability in rural areas, and other high-level analytics that will be pulled into dashboards. Our third initiative is Workforce Recruitment and Rural Access Program. So our goal with this is to attract and retain healthcare providers in rural areas of the state. So it's funding a variety of strategies focused on growing workforce, offering initiatives. And we'll be looking primarily at measures of number of care providers and high need specialties and care settings for this initiative. And the OOA will be building out a provider network dashboard that will be able to monitor these types of statistics with. Fourth and final initiative is the Rural Health Innovation and Technology Grant. So this establishes a program with the aim of improving interoperability, health system connectivity, and security. So potential programs under this initiative would include things like telehealth services, remote patient monitoring, which was mentioned earlier, tech-enabled hybrid care solutions, and mobile app-based programs. We also have a plan for all funded programs to need to account for participation in CMS's interoperability framework under this initiative. And with this, we'll be looking at things like telehealth service utilization, which the Office of Analytics through NBHA already monitors through our telehealth dashboard, as well as provider participation in CMS health technology ecosystem, number of successful grants for innovative tools, and cybersecurity. So we recognize that in addition to some of the very specific specified metrics on outcomes and utilization that the Office of Analytics will be measuring, we will also need to monitor administrative data and program data, things that we actually don't really currently have data sources for. So we'll be working very closely in partnership with the Office of Analytics to develop data collection, management, and dashboarding processes in order to monitor program administration in addition to the metrics. So I think I'm nearing my end of my couple minutes to chat. So if anybody has any additional questions or thoughts, I'm happy to answer them now or after our next speaker. And Alicia and Dylan can probably help support me in that as well if I can't answer.
Okay, great. Thank you, Jonathan. And so next we're going to go to Ina Backus, who is from Freedman Healthcare, and she is representing the state of Rhode Island. So Ina, go ahead and give us your presentation. And then after her presentation, we'll take questions for either of the states or for Julie for that matter, before we get into our discussion.
Thank you, Norm. I'm going to go ahead and share my screen. And like Julie, please let me know if you're able to follow along and to see my screen. Whoop.
Yes, you had it there for a second and then it went back to there we go. That's perfect.
Great. I'm glad you can see it. Thank you so much again for this opportunity to speak with you today about Rhode Island's Rural Health Transformation Program application and plans for implementation. My name is Ina Backus. I'm a senior consultant with Freedman Healthcare, and Freedman Healthcare assisted the state of Rhode Island by analyzing and compiling data to support the Rural Health Transformation application. I want to call out the fantastic staff in Rhode Island who not only put together a fabulous application, but also led a really impressive stakeholder engagement process in a very short period of time. As Julie said, this was a very compressed time frame for states to put together applications. I'll talk about the application and how data was used to inform it, and one of the initiatives that Rhode Island is planning to implement specifically to strengthen data for rural health transformation. Again, I'm really thrilled to be a part of this discussion today, and with such a compressed time frame for the application preparation, I think it's a really great opportunity to be able to talk together about the learnings. There were so many learnings produced from the process. So first, I'll give you some context by talking about Rhode Island's rural health transformation vision, goals, and initiatives. And then I'll speak about the data sources that were used to support the application, highlighting the APCD and what was proposed for outcomes measurement. As Julie said, at least 4 metrics were required for each initiative. And then I'll close out by looking forward to implementation and describing one of the initiatives that was proposed specifically to strengthen data for health transformation. Here's Rhode Island's vision for rural health transformation. The Rhode Island Rural Health Transformation Program will strengthen access to high-quality, sustainable, and community-driven healthcare for residents of Rhode Island's rural and island communities. The state's vision for rural health transformation is a connected, community-based system that ensures every rural resident can obtain timely, coordinated, high-quality care where they live. And there are 5 mutually reinforcing goals that promote this vision and that align with CMS's strategic priorities. With Goal 1, make America healthy again and improve the health of rural residents. Goal 2 being sustainable access, expanding access to comprehensive quality low-cost care. Goal 3, workforce development, strengthening the rural healthcare workforce. Goal 4, innovative care, accelerating value-based and affordable care models. And Goal 5, tech innovation, integrating technology into rural practice. Rhode Island is also engaged in a statewide healthcare system planning initiative, and in this work, along with the rural health transformation program initiatives, really share a very strong data-driven approach. Now I'll turn to the initiatives. Rhode Island put forward in its application 13 initiatives. We'll walk through these at a glance, and I've highlighted Initiative 13 because Initiative 13 is focused on improving data for workforce tracking, for rural health, and for monitoring outcomes and guiding policy. Rhode Island also proposed investing in community and clinical care hubs and rural community health networks, rural community integrated and mobile health services, accessibility investments for rural providers to expand physical access and disability competent care, expanding EMS capacity through paramedicine, education academy, and enhancing island operations, a hospital at home program, behavioral health services expansion, oral health access, including teledentistry and special care services, place-based investments for Block Island Health and Human Services, investment in the Narragansett Indian Tribe health systems, rural workforce program to expand training, placements, and recruitment incentives, supporting value-based payment transition through incentives and technical assistance for hospitals and primary care, technology modernization through a state-sponsored electronic health record, and grants for health information technology. And as I said, rural health data and workforce tracking system for monitoring outcomes and guiding policy. We'll turn back to Initiative 13 in this presentation. And now we'll move next to a look at how these initiatives corresponded to the data sources that were identified for the program application criteria, which was to outline performance measures and outcomes for each initiative and to include at least 4 quantifiable metrics for each initiative, and specifying that at least 1 metric needed to demonstrate how the impact is distributed in different parts of the state, which really means that data needed to be available at the county or community level of granularity. Data from Health Facts Rhode Island, which is the state's all-payer claims database, helped to meet this requirement, particularly because these data contain the full date of service and member city, state, and 5-digit zip code. And as you can see, I've divided the initiatives here. These are the first 6 initiatives that I reviewed. And you can see that the APCD is featured as the data source for many of the metrics that were identified for measuring progress against each of these 6 initiatives. Specifically for Initiative 1, the APCD is the proposed source of data for all of the outcome measures. Moving now to the other outcome measures, the APCD or Health Facts Rhode Island is also featured here for oral health access, including teledentistry and special care services, as well as place-based investment for Block Island and Health and Human Services. I also want to point out that the Rural Workforce Program to expand training placements and recruitment incentives is really the evaluation of this initiative is really linked to Initiative 13, which will improve workforce tracking system and enhance the existing workforce data hub. In the next slide, I've provided an example of the metrics that are going to be stratified by geography for evaluation of the initiatives in designated rural areas. And you can see, similar to the themes that Julie identified in her review of all of the state's application, that the All-Payer Claims Database, or Health Facts Rhode Island, included metrics including cancer screening rates, well care visits, preventive dental services, dental-related emergency department visits, potentially avoidable emergency department visits, rates of hospital inpatient admissions, rate of behavioral health emergency department visits, and behavioral health services utilization. The plan indicates how the metrics will be reported relative to the rural designations in the state. And again, these metrics really align with what Julie captured in her review of multiple state plans. I'll wrap up by zooming in a bit more on Rhode Island's Initiative 13, which is to develop a rural health data and workforce tracking system. The state already has rich data assets that describe population health and health system performance, and the state publishes analyses through dynamic dashboards. However, not all of these dashboards stratify data currently according to rural or non-rural groupings, for example. And one component of the health data and workforce tracking system will specifically focus on enhancing existing data dashboards with geographic stratification. The second priority in this initiative is to identify and capture actionable data to improve care coordination and service provision across health and human services settings, and to better understand upstream drivers of health, also referred to as social determinants of health. This work will also identify data and stratify it by geography to ensure a comprehensive view of the factors that impact rural health. The state of Rhode Island already has a healthcare workforce data dashboard, but the initiative recognizes that the dashboard can be further enhanced with new data inputs, potentially new survey data captured with licensure, and data from the APCD. A comprehensive statewide healthcare provider tracking system can expand the provider types that are included in the data hub and enable better assessment of workforce distribution between those rural and non-rural regions in the state. In each of the activities described so far, there is a clear priority to stratify data by geography, or to collect and develop new data with geographic stratification, using geography as that common unit of analysis. And the final component of this initiative really culminates in these integrated community health data profiles that bring together and integrate data points at the community level and paint a picture of health status, the upstream drivers of health that contribute to overall health. So these pieces work together and will work together to both inform and potentially govern the implementation of other initiatives, as well as to provide for inputs in the evaluation and monitoring of progress in implementation of the full slate of initiatives that Rhode Island has put forward. I'll close out by saying that this initiative, Initiative 13, was really informed by the process of identifying and analyzing data to be used in the application, and it aligns with and it supports the monitoring of the other 12 initiatives in Rhode Island's plan. But it really does reflect a lot of that compressed work that happened over time to identify the initiatives and the metrics and evaluation plan to put forward in the application, and then looks back on that work on how data can be used ongoing in the implementation of the program to improve overall outcomes. Finally, all of the information that was featured in this presentation is derived from the Rhode Island Rural Health Transformation Program application project narrative. It's available here if you want to check it out. And we welcome questions over email and look forward to discussion that's now coming up. So I'll turn things back to Norm now.
Thank you. Thank you so much. That was fantastic, all of you so far. So let's go ahead and take any questions. If you have questions, raise your hand or drop your question in the chat. And we're going to also then have a discussion as well. So Melissa, go ahead. Melissa, can you take yourself off of mute? Okay, try now. Okay, we're not hearing you. So let's go to Gevik and then we can come back to you if we can get your audio working. Gevik, go ahead.
Can you hear me?
Yes.
Perfect. Great presentations, everybody. Thank you. My question is for Julie. One of the slides, one of the focused areas was the data infrastructure. And my question is, what does that really mean? Does that mean adoption of standards? Does that mean adoption of universal consent management? Does it, like, could you break that down for us?
Sure. And you're right that I was a little bit vague on that for a couple of reasons. One is that it's not my area of expertise to go like really deep on some of those issues around like permissions and data standards and those sorts of things. But another is that it's a really broad area. So what I was thinking about when I put that on the slide was things like there's states wanting to create, in some cases, either regional or statewide data hubs that sometimes combine data from all payer claims databases or hospital discharge databases with other sources of data. So, and it really varies across states. So sometimes they want to, make a resource that includes information from community-based organizations to really sort of facilitate meeting health-related social needs. Sometimes it might mean integrating claims data with data from EHRs for like some other types of purposes. And so it's really broad, and I would be going beyond my expertise just to be much more specific than that.
If I may ask a quick follow-on or add a follow-on, and maybe this, is that we know that historically CBOs are very cash poor. So I suppose the hope is that some of this funding can help them unlock both access to the data and sharing of the data that's important for the patient circle of care to take advantage of. So I don't know if anybody has the answer to that, but that would be really interesting to see.
I agree. It would be, and I saw that in at least one state application is that that's part of what they would like to be doing, using the funding for.
Okay. So we do have a question from Jake that's here in the chat, but I'm going to leave that for part of Brittany's presentation or her discussion as well, asking about interstate collaboration. So we'll just hold on to that for a second and we'll get Brittany to come back to that one. Melissa, were you able to get your microphone to work?
Yes, can you hear me now?
Yes, now we can.
Great, thanks. The link that was on the last slide from the Rhode Island presentation, I couldn't copy it and it wasn't active. Could I get that link, please? Perfect, thank you.
Great, thank you. Thank you, John, for providing that for us. All right, let's go ahead and invite Britteny Matero from Innsena to come on screen, and she's going to just give an introduction. We're going to have a facilitated discussion focused on, so wonderful for Nevada and Rhode Island. Congratulations on being successful. But what about the rest of us? So, Brittany, go ahead and turn on your camera, turn on your mic, and turn the time over to you.
Perfect. Can you hear me?
We can hear you, yes.
Awesome. I don't know why, but it's not letting me share like the 2 slides that I have, which I think is fine because I'm chatty and I can just like say all the things. So, appreciate the conversation. I think it's really great. Really, Julie at the beginning sharing about sort of all of the things that are across the different rural health transformation plans is really important. I think there are a couple of things to think about as we get into conversation here around, how can health data organizations, really plug in. One is that like there really isn't a one size fits all across all states. The different plans are different state by state. They all have different priorities, different ways that they are engaging. But I think that the thing to know for everyone that's on this call who is with a health data organization is, these plans are really about initiatives, not necessarily about vendors, right? Like there are some vendors that are sprinkled throughout, but really it's about how are we going to transform rural healthcare? How do we think about bringing in telehealth, remote patient monitoring, stabilizing workforce, moving towards value-based models, working in behavioral health, maternal health, tying in oral healthcare, all of the things, right, that are in these initiatives. And the way that health data organizations can really plug in and start to think about this is all of these things that are dependent on data, knowing where rural patients go, being able to track leakage, transfers, referrals, understanding total cost of care, being able to measure access, wait times, those data pieces that are really critical, not only to understanding where we're at today, but where we're going in the future. What are we being successful in? What needs to be tweaked and changed? And how do we go about that? So, I think that there's a couple of ways, if you're not plugged in today, that you can be thinking about how to approach this. And the first is, identifying who in your state is actually running the work. Sometimes it's the state health officer, sometimes it's the state Medicaid. It really varies state to state. So really understanding, where that lies and who's moving the ball on that. Actually reading the state's plans and understanding where and should you fit in. Showing up now. So most of these states are in the process of getting their cooperative agreements in place, making sure that they, do any budget reconciliations that are needed. Some states are going to have to go to their legislatures. Others are able to start spending funds immediately. And you can show up now. So figuring out where the table is and getting yourself into that and getting invited to it and realizing like you don't need to be funded yet to be formative. You can help to start thinking about how do we operationalize all of these ideas and what should that look like? And then framing your value around the problem and not around your product. Vendor fatigue is a real thing. Probably many of you have been at conferences where they've been talking and you've had state Medicaid directors on that have said, like, if I hear from one more vendor, like that might be the end of me. And so, you really need to come with what are you solving for, right? Be valuable in the conversation. Think about what data is not available today that really needs to be available. And then really think about like, how do we solve one problem at a time? And what does that look like? And again, like, where can I jump in and be part of this conversation? I think there are things that are really important. There are a couple of states that have already jumped in and are starting to do things. Alaska is holding a 3-day convening. Actually, this week it started today for virtual. And then they're doing a health IT vendor day where they took, applications from vendors who wanted to be able to present and talk to people. They're bringing it, to the providers who might be getting money so that they can start to think about like what's right for them. New Jersey's already issued an RFA, again, thinking about, where should they be directing money and getting ideas for initiatives and things that are going to meet all of what they've put in their own plan. So states are starting to do things, and it's really important, to be present, to be part of the conversation, and to be plugging in where you can. And so with that, we wanted to have some space to be able to talk about, how as different people on this call, maybe from a state, maybe from a vendor, a health data organization, what are you doing today? Are you plugged in? Can you share some ideas with those that are on this call of what's been successful for you so far? And then if there's time, we can also brainstorm some other ways to engage. And also happy to chat through questions and we can problem solve while we're all on this. So with that, I want to, maybe we'll do it with a hand raise. If you would love to share some of the ways that you've plugged in and you've found success and are able to share, do you want to raise your hand and we'll call you and have you talk about it? I don't know that I can see all hands raised, so hold on. Let me figure out how to do this.
I'm not seeing any at the moment, but
okay.
let me just check and see if I can see it somewhere else.
While people are thinking about that, there was a question earlier around interstate collaboration, which states and what are the outlined goals. So it's a great question. I have not seen a lot of plans that specifically talk about interstate collaboration, but I've had a couple of conversations with state Medicaid directors who are thinking about this, right? In places where maybe tribes are across both states or, there are people who are, going in and out because they're on a major highway or whatever. So again, I haven't seen a call out to this, but I have had conversations and I do know that people are thinking about it. There was some language around rural health, the initial rural health opportunity that talked about, you couldn't say that you were spending money for another state. So it's really going to be figuring out how do we do this and still stay within the guidelines of the funding. Others, are there any questions or are there any things that you've been thinking about that you would really, love some of those that are on the call to be able to talk about? You guys, it's such an exciting topic. I'll keep talking if you don't raise your hands or drop anything in chat.
Okay, Kyle's got a question for you in the chat.
Great. Any advice on interactions requests for teaming agreements with the big dogs versus keeping independence? Again, I think that is my personal opinion is, I think we're all going to have to think about partnerships here, right? And what does that truly look like? And does that make sense for your business and how you operate and what you want to be part of? Does it open the door for you to have, more skin in the game or be able to really deliver value in a way that you haven't been delivering it before? I don't know, Julie, if you're still on, if you have any thoughts on that either.
I don't know specifically to that question, but one of your comments, Brittany, really about cross-state collaboration really made me think about the importance of thinking about that as it relates to rural healthcare. So I live in Minnesota. From my experience as a state policy official, that the entire western half of the state goes to North and South Dakota for about 25% of their hospital care anyway. Yeah. So if you think about strategies that are about people who live in rural areas, if we're not thinking about travel across state boundaries, then we're missing an important opportunity.
I so agree with that, Julie. I think, where this is where health information exchange becomes really valuable, right? And the national work that has gone on around interoperability as well. Paul, I see you have a hand raised. Thanks for being off camera this entire time too. It's nice to see a face. Paul, did you have you're still on mute.
Yep. Paul, are you with us? No, we can't hear you. You're on mute.
I can't unmute you. Norm, can you unmute?
I cannot. Now we can, yes.
Oh, wait, there he goes.
Sorry about that. Welcome to modern technology.
Yeah.
I have been in this field over the years, certainly trying to find fundamental problems to deal with. I want to focus on the question, the role and placement of HIPAA privacy regulations. The vendors that you're referring to that are participating in innovation, in many respects, need to academics in order to deal with the HIPAA regulations, having review committees to make sure that nothing is going out of line with this data. This was particularly important as we cross state lines. I'm from New York State. I've been doing this for 30 years and trying to get all the data for those patients that cross the boundaries of New York to Connecticut, Massachusetts, Pennsylvania, New Jersey. These are monumental tasks. And then you have to translate the data one format to another format in order. Any thoughts or comments about the privacy, confidentiality, and the difficulty of vendors dealing with research capabilities?
I love that you called that out. I will say that I've talked to a couple of states around actually setting up like data quality and metrics committees that can talk about these things and really dig into them and the importance of it. Not only for the reasons you mentioned, Paul, which are like tremendously important, right? But also this, when we're dealing, I'm from Alaska. So like almost everything becomes identifiable, right? In some of these communities when we're talking about rural communities because they're small. And so how do you also really protect, you know, the patients, right? When you're thinking about data and data exchange, even within a state. And so one of the recommendations that I have had, and like I said, that I've been giving is, you know, set up your committees now. Start thinking about who all needs to be at the table to be discussing this, because it's going to be tremendously important when you think about agreements that need to be in place, what can and cannot be exchanged. You know, how are you, who, you know, who all needs to be there, your academics, your data organizations that are actually providing the data, your consumers of the data, right? Like it needs to really be thoughtful. And I think it needs to start sooner rather than later.
Just to come full circle a little bit, what we began to identify as we were trying to create very large applications for individual institutions is that the prevalence or the epidemiology of rural health is entirely different than suburban as well as urban centers. So differentiating the geography as well as the prevalence measures becomes an important indicator of what's going on. In the case that I'm making reference to, Westchester Medical Center went at Medicaid risk 7 counties of New York State, effectively 14 million people.
Yeah.
So to have a hospital become the insurance company is a monumental task. And there were 7 applications in the state of New York covering the entire state, but the only ones to make a profit in the application was Westchester Medical Center, because we understood the epidemiology of the population, not the individual patients.
Yeah. Yep. So important. Yeah. I think if there's one more question or comment, would love to take it. I'm not seeing any hands raised. So I'm going to actually say one more thing, and that is, I also think that as we're thinking about the rural health transformation and plugging in, there are a lot of opportunities that are coming out through CMMI at the same time that really kind of line up with the work that's happening in rural. And I think that there truly is an opportunity for states, health data organizations, those that are doing the work to start to think about how do we weave it together so that there, is that full picture, and we're really thinking about, what we're doing in rural, bringing it into urban, how it all fits together and works together, and how we can leverage some of these opportunities to truly think holistically about statewide and national healthcare. Kimberly, we have 2 minutes. If you could be quick, we can do it.
Oh, I just wanted to jump in and say, I do see a lot of similarities across the state. I'm from Maine, the University of Southern Maine. I work with the Maine Health Data Organization and the Maine Quality Forum. We weren't that involved in the application itself, but we are named, actually, MHDO is named as certainly providing data for some of the metrics. But what I see, and I haven't had an opportunity to look at all the other states, but in a little bit that I've looked at them, what would be really helpful is to actually have a cross-state application analysis, because there's a lot of potentially similar metrics, as Julie was pointing out, and that it would be great to figure out how to collaborate on actually creating those metrics so that we aren't all doing the same thing and spending the money to basically produce the same thing. So that's just my call out for as much partnership as possible so that we are utilizing the funds most effectively on the data side, and benefiting hopefully rural citizens by doing so.
Yeah, I love that. Actually, I'm going to pop that over to the newly formed Office of Rural Health Transformation, and just mention that they are pulling together states only in March to be able to start to think about some of that. So if we can get a head start, that would be great. Norm, back to you.
All right, thank you. Thank you to all of our presenters and facilitators today, and thank you everyone for showing up. Fantastic opportunity for us to get to see you and to meet with you.